I'm Dr. Sabrina Siegel with the Neuroscience Education Institute, and twice a month I sit down with a renowned mental health care expert to discuss breakthroughs and best practices for treating patients with mental illness. In this episode, we are talking about patient assault on clinicians, and I have here with me today Dr. Rona Hu. She is the Associate Dean of Academic Affairs at Stanford University School of Medicine. She is also a clinical professor in psychiatry at Stanford University, and she is the former medical director of the acute psychiatric unit at Stanford, where she has been for 20 years. Dr. Hu, can you share your experiences with patient violence over the course of your career for 20 years as the medical director of the acute psychiatric inpatient unit at Stanford Hospital? What are some ways in which a clinician can identify and evaluate the risk that a patient may turn violent?
That's a great question. Probably the most important thing, actually, I'll divide this into two parts, if I can. One are things that you should probably do just as a whole, even before a particular patient comes through your door. And then the other is how to identify risk in a particular patient. So the first is to evaluate your safety and your setup, because patient assault on clinicians can happen in a lot of different settings. So both of the ones that I mentioned were in the hospital. It's important to have teamwork. And when you're doing a physical exam in an examination room, to have someone else present and to let other people know what's happening. And when you're interviewing a new patient, to let people know and to have other people around. Later, when you know patients better and they're less unpredictable for privacy's sake, you can often have an interview with a patient with the door closed. But initially, one should have it with the door open and with someone else either in the room or nearby until you know a little better this patient's current status is like and also what their history is like. I encourage people in private practice and in group settings to have the office set up so that they don't have a lot of heavy throwable objects, big old paperweights, one of those letter openers that looks like a sword. There's a lot of ways in which you can take a look at your office and try to make that as safe as possible. Ideally, offices and examination spaces would have 2 doors, but that almost never happens. That's kind of an idealized wish list. But given an office with just 1 door, if you can have a panic button, something that alerts other people, and have it where you can readily get to it. When I first started my clinic here at Stanford, I inherited an office from an analyst who didn't see very acute patients. And so when a patient, not even someone who was either psychotic or agitated, but someone who was looking for pain medications, threatened me with a metal cane, I realized that my panic button was behind the file cabinet. I would have to pretend I was dusting back there or something in order to press the panic button. If the panic button's right near the door, then if the patient is blocking you from the door, you can't get to the panic button either. So make sure it's in an accessible place. If a patient, in the case of the one who wanted pain medications, she was threatening me with a metal cane. If I could get to the door, then the best thing to do would just be to flee at that point and not stop to do anything else. In this case, I ended up calling the receptionist and putting the phone on speakerphone so that she could hear the yelling. And she asked, Dr. Hu, are you okay? And I said, no. And then she sent security over. Teamwork is very important. If you can have a code word between yourself and your colleagues, that's important. But also just each time you see a new patient or deliver bad news or say something to a patient that you know is probably not going to take it well or might not take it well, to alert colleagues and have them be alert to any sounds. And then I mentioned in the first one that the patient broke a wooden chair against the wall and chased the resident with the splintery parts. We now have better chairs that aren't throwable and aren't breakable. Things like that are helpful. Taking a good look at the surroundings in whatever clinical space that you have and trying to make those safer. And also working with colleagues to realize that this is a potential risk and figure out what to do that can make it better. So those are some of the things that can be helpful for making the space safer. You should also think about how you're dressed. I tell the residents this and the medical students from day one. We're required to wear badges, and if you have a lanyard that has a magnetic or pop bead in back, that's the best. Lanyards are sort of long and pullable, and an agitated patient can either pull on that and drag you, or someone who's agitated and isn't even meaning to hurt you. Some of the times that patients have become assaultive are someone who's demented or delirious or confused. Something very simple like checking their blood pressure. Their arm suddenly starts to hurt and they don't know why. And then they'll sort of claw at the nearest person or grab something. And so lanyards should be something that comes off very quickly and easily without hurting you. I advise the male residents to dress neatly, but without neckties unless they have to. But really, the standard necktie is a noose. It not only goes all the way around their neck, but it tightens if somebody pulls on it. It tightens very obligingly and is very sturdy fabric. The standard necktie is actually quite dangerous. I was just talking to a resident who, developmentally delayed patient, asked him, "Does that go all the way around your throat?" And then he got the heebie-jeebies. He got that alert feeling on the back of his neck where the patient was trying to figure out if this would be a way to assault the resident.
Right.
And then for women, I have a collection of jewelry with magnetic clasps. So if someone were to pull on them intentionally or unintentionally, they just come off. I advise people not to wear long dangly earrings or hoop earrings. No one's going to try to torture you to death with your studs, the little teeny earrings, but very long loopy things that are easily pulled. Having long hair up or back where it's not easily pulled, either by the patient himself or herself, or in the confusion of a team of people trying to get out of the room or a team of people crowded into an ER. There's a lot of settings in which any sort of loose hair or loose jewelry can get caught and hurt you very badly. And then I always advise people to wear closed-toed shoes. In our hospital, we require that nursing staff wear closed-toed shoes. And the physicians, it's less regulated, but I still think it's a good idea to wear closed-toed shoes that you can run in. High heels are probably bad, not just because it's hard to run in them, but it's also hard to pivot and back out of the room if you need to very quickly. So those are things, even before we get to a specific patient, those are things that a clinician can do that make you safer. So now to the question of how to identify and evaluate risk in a patient that might turn violent. The best predictor of future violence is previous violence. So one of the problems with my stalker was that I didn't know anything about his background. In those days, we had paper charts. At some point, 7 volumes, several feet high, of charts turned up, and I found out about all these other acts that he had done with both male and female clinicians, but that wasn't available to me at the time. So knowing what you can about prior acts of violence, and as much as you can know about that, I encourage trainees to, when presenting, to talk a little bit more. So if a new patient comes in and they say, the patient is here for behaviors concerning for assaultiveness or threatening behavior or something like that, I want to know more details. What, if anything, triggered it, who the intended victims were, what happened, and so forth, if any weapons were used, and so forth. In terms of weapons, you should make sure that a patient doesn't have access to weapons even before they get to you. That includes, obviously, anything around the office that can be used as a weapon, but also when patients come into the emergency room or come to your clinic or so forth, you want to make sure that they don't have weapons with them. It's very important. Other ways of evaluating the risk, there's so many different types of risk. One of the reasons I wanted to choose 2 different patients was because they were very different. After a stalking incident, a lot of times trainees will say, I'm going to be less friendly with patients or so forth. I remember back when I was an intern and people say, oh, it's because you're so pretty or, you smile so much. And I thought, I'm never going to smile again. But in the second case, the patient got angry that the resident was putting him on a healthier diet and became assaulted. Being too friendly or too unfriendly, neither is the solution, right? Doing everything that the patient wants you to or not being friendly, neither of those is the right thing to do, right? Risk of a patient becoming violent can be from their being psychotic. And so that's a different evaluation than if they're confused, delirious, or demented. And then that's also a different risk than if they are wanting pain medication from you, wanting benzodiazepines, other abusable things. Each of those are different. So someone who's in completely clear sensorium, kind of gaming you a little bit, you're going to handle that differently. The patient who said, you're going to regret that, or I wouldn't do that if I were you, that should make you worried and on guard. And that might be a good time to end the interview and then go get somebody else to help out. The person who is psychotic, watching their body language and their eye contact, noticing, for example, nonverbal cues. They're sweating suddenly more. They're looking around the room. And I've often asked a patient, it's like, you started to look different just now. What happened? And the patient saying, the voices just told me that you're one of them. Or in one case, a patient was drinking a cup of coffee, looked at me very strangely, and I said, what just happened? And he said, you were walking over there and you kissed me. And I said, I'm all the way over here. And he said, well, I was drinking my coffee and your lips met mine. And I said, I think that's the reflection of your lips in the coffee. I'm going to stand way over here and try it again and see if that happens. But thank you so much for telling me. So one thing that I do with confused patients, with psychotic patients, is to make sure that you know as much as possible about what's happening. So I don't punish them for telling me if the voices are saying something scary. I thank them. After the patient confirmed that it was his lips that were reflected in the cup of coffee, he said, but I still think you kissed me. And I said, okay, well, thank you for letting me know. I didn't, but I do appreciate that. That would be really confusing. So let's adjust your medication so that you have less things like that happening. The patients that are trying to get something from you, whether it's double portions on their tray or abusable medications, they're going to handle it differently. But you should be aware and alert for that and really pay attention to evaluating that. So in summary, if you can have a friend or family member present for the initial interview or someone who can give you information from before, that's very helpful. And then above all, be alert to the signs from the patient as they're in front of you that they might turn violent. Remember that violence isn't always from anger. Sometimes it's from fear. You know the phrase, the smell of fear? If their body odor suddenly gets dramatically worse while you're sitting there, that's probably fear. If the veins on their temples sort of start bulging, or when you shake their hand, they're sweaty, and a lot of times you start to get the feeling, even if the patient isn't saying anything, that something is frightening them and that they might lash out. So at that point, you want to be extra alert. And then teamwork is also essential, as I talked about in making the overall setting less dangerous. As I was talking about paying attention to nonverbal cues, this is something that I think is more and more of an issue with all of us, and especially with trainees, is that we're required to document and we're required to ask certain questions. So a lot of times we'll be checking something on our laptop or something and not looking at the patient. There's more and more of that now, but I try to train people to be on the alert, even as they're entering an order into the computer, right in the patient's room or something like that. Even as they're doing that, to always have one eye on what's going on. And then be ready to go away and come back if things start to feel funny. So another rule of mine is that I don't give bonus points for machismo. If you're thinking, I'm starting to feel scared, but I'm going to tough it out, that's often a bad decision. So I would advise people to listen to the little hairs on the back of their neck and go away and come back if they need to. If the patient is starting to escalate, then you can say something and then come back.
What are some de-escalation interventions that clinicians might find useful in these situations?
I would always start by listening. Listen to what the patient is saying or pay attention to what the patient is doing. Make sure that they know that you're listening. So a lot of times when patients are starting to escalate, it's because they feel like they're not being listened to. Sometimes you can paraphrase some of what they're saying back to them without necessarily agreeing, but letting them know that you hear them. So, for example, if the patient is wanting to leave the hospital and you can say, yeah, it sounds like you want to leave. I hear that. And then it sounds like you feel like you've been here too long. Things like that. Being able to say it back to them in a neutral way. You can make it clear that you hear the feeling behind it without arguing about any areas in which you have factual differences. For example, I've actually heard people say when the patient says, I've been in this emergency room for 7 hours. And then the clinician's saying, no, it's only been 4. That's not going to de-escalate the patient. I've never heard a patient then say, oh, you're right.
Right.
It's 4. It still feels like a long time. So if the patient is saying something that is factually untrue, but is scary, you don't have to agree with them, but you can let them know it's scary. There's a microchip in my brain. No, there's no microchip in your brain. So to listen, what's happening? What are you experiencing? And I hear these voices oh, that sounds really awful. Let's do something about the voices. If the patient has a specific behavior that is scaring you, you can sometimes give feedback. If you don't feel comfortable with feedback and it's starting to get scary, it's probably better to leave the room and come back than to try to tough it out. For medical students and residents early in training, I might say that they can, at that point, even pretend to get paged or texted, and I give them permission to lie in that specific incident. If you can give feedback, for example, you're calling me a lot of names right now, and I really want to help. So if you talk to me with respect and I talk to you with respect, then we can work on this problem that you have. And sometimes I'll make sort of a analog chart with my hand to show us oh, that's a little loud. Oh, okay, good. We're now at this level. Let's talk at this level. And then say, oh, it's starting to get a little loud again. Listen, I'm going to go away and come back with someone else since you're calling me names. But I keep my voice neutral. If somebody calls you a moron, you say, I'm a doctor. I'm not a moron. That's not helpful, right? Arguing is not a good way to de-escalate. Pulling rank is not a good way to de-escalate. So if they're sort of I don't have to do this, well, yeah, you do. I can tell you need to follow my orders or things like that. Those are not a good way of de-escalation. And I'm laughing a little bit, but a lot of these I've actually heard in real life. Someone says, you're an idiot. And it's yeah, well, I went to medical school and you didn't. People are often under stress. They'll deal in various ways. But de-escalate by listening first and then trying to find some shared goals. A lot can be done by offering comfort measures. A lot can be offered by something that is a little distracting, not so much, oh, look over there, but sort of offering them something to eat or drink. If they've been in the emergency room for a while, if you're bringing them into the hospital and they really haven't eaten in 8 hours, then something to eat or drink is helpful. If they're paranoid, sometimes I'll get 2 cups of water, show them that they can see me opening the bottle a little distance away, and then they can choose, and then I'll take the first sip so that they know that there's nothing in the water. Be careful with offering scalding hot beverages. If they're getting coffee, then you might let it cool down a bit or ask them if they want a little bit of creamer or something to stir it up and make it a little bit less hot, or put one of those sippy cup tops on it or something like that. But yeah, when somebody is screaming, then I say, I wonder if you're thirsty. I'm kind of thirsty. Here's some water. I'll have some too. And then we both sort of sit down and have a cup of water. In the beginning of the situation, you're going to be standing and nimble and ready to back out of the room or run or whatever if you need to. If you have somebody nearby that can watch, then at that point, if the patient's sitting down, then you sit down too. I've definitely worked with trainees who were told early on that they should always be at the patient's level or lower. I think that's good advice when there's a group of people towering like trees over somebody in bed. That's very intimidating. But when the patient is getting agitated and there's just one of you, I would prioritize safety over rapport at that point. You can gain rapport back again later. So when trainees crouch down on the floor next to the gurney or bed and they're within easy kicking or grabbing distance, then I encourage them to get up off the floor and stand a little bit further away and still be friendly and helpful, but just not physically right where they can be grabbed or hit. If you're getting shared goals, don't compromise on safety and don't throw anybody else under the bus. And believe me, I've heard both of those. So if you stop yelling now, you won't need to get any medication. If they really do need medication, then that's not a good bargain to strike. And obviously, if they have weapons, if you don't point that at me, you can hold on to, you don't want to do that. Any sort of weaponry, put that down and kick that over to the corner, and then we can talk. But right now, we can't. That sort of thing. You don't want to compromise the safety. Don't throw anyone under the bus. Believe me, I've seen that. I've overheard it when I wasn't meant to overhear it. And then I've also been there when someone is saying, the other specialty thinks that you can't go. I think you're fine. I'd like to give you pain medication, but my attending won't let me. That sort of thing. Don't do that. That's not helpful. And when a patient is starting to focus on one person, I do try to generalize it and say, that doctor served me an involuntary hold. And it's like, he gave you the paperwork for it, but actually all of us are in agreement that you need to stay in the hospital right now. So even if not all of our names are signed on the hold, we actually agree. And so making it sort of a group decision rather than any one person. First of all, it's accurate. And second of all, it helps keep the patient from focusing on one person and trying to solve that one person. So sometimes the patient starts to get a little bit of insight. My parents think I need to be in the hospital, and my boyfriend thinks I need to be in the hospital, and everyone in the hospital thinks I need to be in the hospital. So they might all be wrong, or maybe I need to be in the hospital for just a little bit longer. When I said going away and coming back later, if you give them a specific timeline, that's helpful. And so saying, I'll be back in 20 minutes, I'll be back in 5 minutes. If there's a clock available to the patient or they have a watch, it's like, I'll be back at the top of the hour. I'll be back right at 10 o'clock or something like that. If you just sort of leave, even when the patient is shouting at you, if you're sort of like, okay, you can't talk to me this way, I'm going to go, they can feel desperate and then they'll escalate to try to keep you in the room or grab you or something like that. So you say, you're calling me names right now, and it's hard to help you when you're doing that. So I'm going to come back in 5 minutes and I'll come back with somebody else. And then let's try to work on getting you out of the hospital when you're stable and keep it neutral and calm. Even when the patient wants to get you riled up, neutral and calm is a lot better. You're setting a role model for the patient, but also if their purpose was to get you upset, a lot of people that perpetrate sexual violence, for example, kind of enjoy it when the intended victim is getting upset. So if you sort of say, ooh, that's not appropriate, let me go get somebody and I'll come back, is a lot better than screaming or getting upset with them. If you do have to leave the room and you're going to come back later, the very next thing that anyone should do, whether trainee or attending, any clinician, is to go and get somebody else and let them know what happened. So we have had situations where the patient screamed, said something to a resident or medical student, and then the trainee flees, which is probably the safest thing to do at that moment. But then they're sort of like, wow, that was scary. I'm going to go get a cup of coffee. And that's not helpful. If they're sort of like, wow, that was scary, let me go let somebody know. And they tell another member of the team and say, look, if you're taking care of the gentleman in that room, he just said something to me that was disturbing, or he just did this. And then either you can go back in together, or two other staff members can go in there and see what's happening. But if the patient is just in the room, still confused or still scared or upset, they're not going to get any better on their own. So this is, again, where teamwork is helpful.
Well, thank you so much. Thank you for joining us on this very important episode and for sharing such valuable information with all of us. Thank you, Dr. Hu.
Thank you, Dr. Siegel.
This episode has been brought to you by NEI Synapse. Are you a clinician treating patients with mental health disorders who wants to use evidence-based science to improve your patient's care? Then this meeting is the one for you. The 2019 NEI Synapse will bring you the new science-based treatments that you can take home to improve your patient's outcomes. Experience incomparable faculty presenters who will share their unique experiences and offer key clinical applicable insights on the latest in mental health care, bringing your knowledge up to date in the field of psychopharmacology. Register now. Seats are filling fast.